Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
So, James, there was an approval last week that we saw in the US, though it was part of Project Orbis. So maybe it wasn't just in the US, and we can hear more about that. We'll talk about that. And it was for a subcutaneous formulation of the drug that we know as nivolumab, brand name Opdivo. And now they have an Opdivo Qvantig, which is the subcutaneous formulation. So we thought it was probably a good idea to talk about that and the Checkmate 6-7T study that led to its approval and across indications and doses. But before we do that, maybe we do a quick fire. I'll give you a choice. You can either tell me about your favorite teacher from like what we would call elementary time here in the US, the equivalent of elementary, grade school, maybe through high school time period, if you have one, favorite teacher, or you can tell us about that Napoleon picture over your head.
Favorite teacher. I went to a school where there were only 3 teachers. Okay. So that would be a choice of 3 because it's a tiny village school. And so there were only 50 children or something in the whole school.
This is in Port Isaac?
Yeah. It was, the one that started off on the building that was on the edge of a cliff, and then which had got closed and moved, and now it was converted into a hotel. So I don't think it'd be fair to choose one of those 3, if you see what I mean. Picture of Napoleon. That's a picture of Napoleon, which used to belong to Martin. And I sort of said this a little bit when we were talking to Monty. When Martin died, which is almost 6 years ago, 10th of January, 2019, we kind of went through his office, and he had just loads of stuff in here, like journals and all sorts of stuff. So we couldn't keep everything anyway. And so we just kept a few, actually there's a few people's theses up there on the shelf and a few books and stuff like that for sentimental reasons. And then pretty much the only other thing that we kept was the picture of Napoleon, because maybe just as a sort of reminder of Martin. And I don't know, honestly, I should find out, shouldn't I, how long he had it and who gave it to him and all sorts of other stuff. But I'm not even sure he would actually know the answer to that, because there aren't that many people left now, honestly. I could ask his wife, actually, next time I talk to her. She may well not know, though, because...
What's ironic is Martin could not be the more physical opposite than Napoleon, right? He was fairly tall and...
Yeah, very large presence. And Napoleon was pretty small, right?
Yeah.
No, and I don't know much about Napoleon's character, but I suspect that was quite different as well. So it is ironic. But the other slightly fun thing is that when I'm doing meetings on Zoom or Teams or whatever, just like this, you can see it over my shoulder, and it's always fun. But who knows that it's a picture of Napoleon as well. Whether people get intimidated about there being a picture of Napoleon on the wall is another question altogether. But,
Yeah, I mean, there's the whole story of why Martin has it, who gave it to him, what it meant for him. Now there's a whole Larkin Napoleon story. The internet is full with screens of you.
Yeah, well, that obviously isn't true. But, so anyway, that's about as much story as there is, I think. I'm thinking getting rid of this table, because we don't really have loads of sort of, in the old days we were having loads of sort of face-to-face meetings around that table, and now we hardly ever use it. See, what I wanted to do was to get a corner sofa. Have I told you this?
Mm-mm.
Yeah, so I think it would be perfect to have a corner sofa there, I don't know. Do you have the word sofa in the US or not? Yeah, you do, right? Anyway, but no one agrees with me. Who always, because it would be amazing because it's a more comfortable place to sit, more relaxed, and also if you fancied a kind of a nap or anything like that after lunch, I would get one that was big enough to sleep on.
Yeah. I mean, look, you're speaking to Americans who know how to put these comfy things in their office. So
Yeah. I'm singing.
nice.
I'm singing to the choir.
Yeah. We could get all that lovely stuff that has like an ottoman and you can relax, a good Herman Miller chair with an ottoman. But the truth is, are you ever going to have time to use it? I mean, it's just going to be more decoration. What you should get that you would enjoy when you have these Zoom or team meetings and you have the odd 7 minutes in from one to the other, or 3 minutes and it's not enough time to really crack into email or do anything, you should just put like a heavy bar or something like that back there.
Yeah.
You could do some reps of something. And
Yeah, I thought you were going to say pull-up bar, but that would be perfect actually because you don't need any time. The problem is pull-up bars take a fair amount of they need to be drilled in pretty
mm.
well into the wall.
And then
So
there's you closing the door, and oh, you would not do it on the door frame. You'd do it on the wall.
yeah, or off the ceiling, but I'm not sure I could justify that to sort of the Marsden's, maintenance department. Actually, there's a guy called Mick. Mick's the key person. If you want something doing, you just ring Mick, and then I'm not sure I could get it past him. It's a bit difficult to say it's a legitimate kind of healthcare related. I suppose I could try and make a wellness argument or something. I don't know. It's always ridiculous now. I think we were watching we watched all the Die Hard films again at Christmas because that's what you do at Christmas, right? And
Because they're Christmas films
sorry,
to a certain population of XY chromosome. That is a holiday film.
yeah,
Okay.
it's not even a question, is it? Anyway, the point is there's all this stuff with Bruce Willis doing all this like overhead stuff, pulling him up and all this, and they never film it properly in films. It's just absolutely obvious they're not hanging because when you hang, your arms are really, really straight, and they're all yeah exactly.
Right.
And there's one I don't know if it's one of the later films. There's just some ludicrous scene in a lift shaft or something where he does a maneuver that basically only a professional gymnast could do. There's just absolutely no way in the world that even someone who was in good shape and fit, it was a professional gymnast stand-up maneuver on a bar. Anyway, that was digression, wasn't it? Right. Should we talk about this study?
Yeah. So tell us about Checkmate 67T and kind of why it was done. Why are we at the point of needing a subcutaneous formulation?
Yeah, so I mean, there's a few subcutaneous formulations out there now, which have got labels. I think from the patient perspective, it's close to being a no-brainer that you could have the option for subcutaneous instead of intravenous, in terms of convenience, possibility of having treatment at home, and so on and so forth. I guess also from an industry perspective, the anti-PD-1s, nivolumab, pembrolizumab, are coming quite close to the end of their patent life. So there's a sort of a fairly obvious commercial type issue there. And this trial, Checkmate 67T, really, I think the main aim of the trial was to establish the efficacy and safety of subcutaneous nivolumab. So it's a randomized trial comparing subcutaneous to intravenous. Quick note on the authors. So I think the trial was mainly recruited in Central and South America. So a lot of the authors reflect that. And in addition, my friend Laurence Albiges, who works at Institut Gustave Roussy in Paris, was the lead author certainly on the ESMO presentation this year. I could even do the citation, which is volume 35, supplement to S1013 to S1014. As well as Sabi George from Roswell Park and Sergio Brigada. So that's the kind of authorship list. Cutting to the chase, randomized trial, basically in second line kidney cancer, where people hadn't had a checkpoint inhibitor. So that's kind of quite relevant actually, because now, 2025, the standard of care in first-line kidney cancer is going to be a treatment regimen containing a checkpoint inhibitor. So there won't be that many patients around the place actually who are kind of, suitable for single agent nivolumab, which has been around now probably for best part of 10 years, and also adjuvant pembrolizumab is being used. So anyway, so it's single agent nivolumab. So certainly in our practice now, 2025, we'd hardly have any patients who are on single agent nivolumab because they're all getting kind of upfront checkpoints inhibitor. Anyway, so so randomized subcutaneous nivolumab, and the other kind of slightly interesting thing here, and maybe we won't dwell on it, is that along with the subcutaneous nivolumab, you get this hyaluronidase, which is given, I think it's in the same injection, and I don't know if you know much about this or not, but you need that for the subcutaneous formulation to become available. And I think in developing these subcutaneous formulations, a massive amount of effort was put into working out exactly what you wanted to do, or what you needed to do to make the drug systemically available. Anyway, so the overall response rate by BICR, they call it a key powered secondary endpoint of the study. The other endpoints of the study, or the other main endpoint of the study, is the PK of the subcutaneous formulation.
Sorry to interrupt, but can I ask you, is that what's required when moving from an intravenous formulation to sub-Q, essentially a PK equivalence? What's the requirement to show this drug is like the other?
I don't know. I don't know what the regulatory requirement is, and I think that it makes sense, doesn't it, that the PK is necessary. I mean, the efficacy is, in a way, maybe that's almost more interesting in a sense, because, is response rate, is that the correct measurement of efficacy? Should it be something else? Don't know. I mean, I personally think response rate is a reasonable surrogate, actually, in this disease. And the response rate for intravenous nivolumab is extremely well established, but nevertheless, it was a randomized trial.
Can I, sorry to ask you one more time. Earlier, you said single agent nivolumab. There wouldn't be very many people getting single agent nivolumab because most people are getting upfront checkpoint.
Yeah, not in our practice. But 5 years ago, before we were using upfront checkpoints inhibitors, maybe, but now that we really have no patients in clinic who would be getting single agent. So to get single agent nivolumab, you'd have needed to have a first line treatment that didn't include a checkpoint inhibitor. So
I'm following now what you're saying. I was getting a little confused in my head, but what you're saying is to get second line single agent Nivo would have meant you didn't see first line checkpoint, and that's just not the practice pattern anymore. Got it.
Yeah, and if you weren't giving a first line checkpoint inhibitor, there would be a good reason for that. You had concerns about major autoimmunity or something else, and so then you wouldn't be giving it second line. You wouldn't be giving mono second line. Okay.
Anyway, and I don't mean to interrupt again, but I was wondering. This is the American and we can't help. Do you like how I blame the entire culture of American? It's not a personal fault, it's a whole cultural fault. It says the co-primary PK endpoints for non-inferiority testing were time average serum concentration over the first 28 days and minimum serum concentration at steady state. So essentially there were these two PK primary endpoints that were, they were calculating them for non-inferiority. So that's that. Yeah.
And that's a good point. Thank you for interrupting. Really kidding. Anyway, so PK kind of ticked the box, right? In terms of non-inferiority. And actually, if we look at response rate, and I'm looking at the ESMO abstract, it's actually about 20% for intravenous nivolumab, and it's actually 26.6% for the subcutaneous formulation. So certainly not worse. And actually, if you'd asked me what I thought the response rate was to intravenous nivolumab, most people will quote somewhere around 25% from the original registration study quite a few years ago. So it's actually, it's kind of close, but it looks lower. But go on.
Yeah, I mean, in this randomized set, it's lower, but as you're saying, most people would have thought it bangs up closer to that 25. I'm just struck by the fact that the lower bound of Nivo subcutaneous formulation, the lower bound of that 95% confidence interval, is still higher than the median, the objective response rate, not the median, the objective response rate of IV Nivo. That's pretty
Yeah. Yeah, no, I mean, I think that's interesting. So, I mean, may as well just get the numbers out there. So for IV Nivo, the confidence interval is 15.8 to 26.2. So that's around about 10% confidence interval. And then for subcutaneous, it's 21.1 up to 32.6. So like you say, there's a bit of overlap there. There is overlap, but to say what you said again, just to be really clear, the 21.1 for the subcutaneous is higher than the response rate to the intravenous. So, there's a load of other analyses here. For example, median progression-free survival, I really don't think that's particularly illuminating or helpful. Development of neutralizing antibodies is an important consideration. I'm not an expert in this area, but that's one of the concerns here, that the development of neutralizing antibodies could, in principle, impair the efficacy of the treatment. So if you look at the again in the table, the percentage of patients developing neutralizing antibodies, it's kind of about 1% or something like that. So one would hope that that's not clinically relevant or significant. You're frowning.
I don't even understand this table. The way the abstract is written, the numbers are just banging on across next to each, like ANA's N, and then the next line neutralizing ANA's. I get the neutralizing, but ANA's N, 208, 50, 24.0. I don't even understand these numbers.
No, I don't understand that either. And I was just referring to neutralizing when I said it.
Yeah. I think 208 is the sample size they had it on. 50 had it. 24. I don't know. I don't even understand.
Yeah, what you just said is pretty plausible. Yeah, it's not a great table, is it? And then the safety, which is the bottom line here, I think again looks fairly similar. Although it's not very, as you've just said, it's not very easy to interpret table.
Yeah, and in the ASCO, so this originally was published at GU ASCO last year. I think the ESMO was a later update. What do you call that? Life cycle management. The gift that keeps on giving. In the ASCO abstract, they talk about injection site reactions of 8.1%, low grade and transient. It's interesting to me because you said something at the top of this, that this is, kind of a no-brainer for patients, subcutaneous versus infusion. At some point, obviously, if you get to be using this, we'll get to the point about regulatory approval and how quickly you think you'll be able to do Qvantig for your kidney cancer patients. Also, the line of therapy, maybe you just won't be offering it that much for all the reasons you said. But I'm curious, as you talk to patients, are they more averse to a shot? A subcutaneous is a shot as patients would sort of interpret it, right? The needle goes in, the plunger gets deployed, versus an infusion, which we all know is still the start of an IV, but somehow patients may not interpret that as a shot. I mean, yeah, they both come with a needle prick and so forth and so on. But I'd be curious if patients are more averse to the shot version of this than to the infusion, or if it truly is a no-brainer to them because the infusion is time and connection.
Yeah. Well, in kidney cancer, we haven't really talked about it yet, but the FDA label is actually broad. So there's this one trial, but actually there's a load of indications in there, including combination indications. So the main kidney cancer indication probably is going to be nivolumab plus cabozantinib, which is one of the first line regimens.
Got it.
So the point I was going to make is that a lot of the patients who are coming to that, some of them may have had adjuvant treatment with pembrolizumab, so they'll know what intravenous treatment's like, but some of them might not have ever had any intravenous cancer treatment. So I think with that, as it were. I suspect most patients would go for the shot rather than the intravenous infusion, just as a sort of gut feeling. But the way I see it playing, and maybe we can talk about reimbursement and that kind of thing in the future, that if we had access to this, at least on the National Health Service, we wouldn't really be making decisions about this. This is slightly wrapped up in reimbursement because
it's going to come out of our hands and go
yeah,
with the thing. But you bring up two good points that is worth talking about. On the basis of this trial, this is second-line kidney cancer, I think, as you said. It actually has a much bigger approval than that. It is now. Do you have the label in front of you, how it's approved? If not, I can pull it up.
yeah, no, I don't have it in front of me, but basically it's really broad.
Theoretically.
I'm sorry?
We can use it in melanoma. That's, I guess, the point.
Yeah, exactly. Yeah, exactly. So that's the point, isn't it? That I guess from a regulatory perspective, this formulation has been benchmarked against intravenous nivolumab, and the FDA at least has taken a view there, and presumably these discussions took place with the FDA prior to even doing the trial, that they've now got broad label including different cancers and in combination with other drugs, which is kind of interesting. But then, I mean, to take a counterpoint on that, should it be necessary to redo all of your registration trials with a new formulation? I mean, that to me doesn't seem right, actually, I have to say. So I think it feels like it's proportionate, actually.
Yeah, I think that's fair. That coupled with the fact that this is not the first oncology experience changing a drug from infusion to subcutaneous with a hyaluronidase delivery system. And for the fact check, maybe we can just read off the other drugs that have gone, I think we know trastuzumab comes to mind and others, but it looks like there might be 9 of these. I just don't know them off the top of my head. And so yeah, I don't think you have to redo when this kind of technology of going from intravenous to subcutaneous has been already established. Maybe those first few approvals, it might have been important. Secondly, I think it's pretty interesting. This is PK, so you're just saying basically it's equivalent. So where you have one drug, you could plug out one and put in the other. And this will become a regulatory issue. It will be really interesting to see how quickly payers pick this up in the US. And then it will get on what we call pathways, which is like now the pathways will say, if the cost is not cost prohibitive, perhaps switch out this for that, because now you take away the infusion cost, the chair time, the infusion nurse, the 30 minutes plus of nurse time, tubing, all of that kind of stuff that you would normally charge a payer for an infusion. And you're switching it out for, basically a syringe and 5 minutes of nurse time or so. Related, as I'm finding the different approvals and the actual label here that we can read out here at the end. Related, I mean, obviously they look at safety. We saw no issues with safety here, right? You were getting to that in the abstract. I lost my train of thought. Sorry. Cut and pause. It had something to do with nurse time. Oh, you had mentioned to this when we were chatting that I hadn't quite thought about. This is not just a flu shot subcutaneous or intramuscular. This is not a quick, 2 to 5 second push. This is actually a slow subcutaneous push. I mean, I don't have experience with subcutaneous slow pushes like this. So what do you know about these? What's the likelihood it could actually be done by a patient at home versus needing to be done by a professional versus a machine, a programmed pump? To do that.
Yeah, my understanding, and I don't have loads of detail, they actually do quote somewhere the sort of average amount of time, which, and I think that the bottom line there was that the majority of infusions, deliveries, let's call them deliveries, were less than 5 minutes. But in conversations I've had about this, I think most nurses felt it would be quite difficult to do that manually, if you like. And as such, it felt like a pump would probably be necessary to do that. So that's an issue. And then the question, could a patient do it themselves? Well, they'd need a pump if you require a pump. And so that's doable, I suppose. But it's not going to be right for every patient, obviously. And then that brings up the broader question of, does the patient need to come to hospital to have this? Could they have it at home? And so on and so forth, which you and I have chatted about a little bit.
And do we have any understanding? We have certain drugs that are administered via slow IV push. Demerol would be one, that comes to mind. When we say slow IV push, that's still not 3 to 5 minutes. That's not even a minute, right?
Yeah.
I mean, maybe for the fact check, we can even put in there, like, what is a slow IV push technically for a nurse? You can grab your research staff out there and have somebody come tell us. Versus this kind of slow subcutaneous push. This isn't even just slow. This is really, right, like you said, needs a pump, because how could you actually
Yeah, I think that's beyond the limits of human performance, honestly, to give something so slowly in a relatively small volume. Okay,
that's the key, right?
Yeah, over 5 minutes. I don't think it's doable.
Do we know the volume?
No, I don't off the top of my head, but it's from memory. It's not 1 or 2 mils. It's more than that. So you're talking about a sort of, if you think about actually giving this thing a reasonably significant, I mean, obviously massive efforts have gone into minimizing the volume, but it's still not 1 or 2 mils. It's more than that. We can check that as well.
And interestingly, I'm looking at this 6-7T, the randomization, it couldn't have been blinded. Well, obviously it couldn't have been blinded. It's sub-Q versus IV, but it was, Qvantig was every 4 weeks and the Opdivo was every 2 weeks, the IV. So it wasn't even exactly the same administration schedules, as you say. Go on.
I wasn't sure that you did that in my accent there. It sounded like someone else's accent.
Oh.
Yeah, I don't have a massive problem with that, I don't think. That's the kind of the original nivolumab schedule. Is 2 weeks IV about the same as 4 weeks IV? Yeah, we think so, don't we? But again, no randomized trial or anything like that.
Okay, here is the official indication. Monotherapy for first-line treatment of adult patients with intermediate or poor risk advanced renal cell carcinoma. I'm sure you have a whole thought about the risk stratification here. Following treatment with nivo-ipi combination. So it's essentially maintenance therapy for first line. It's also, it's not indicated in combination with ipi. So it's not for the nivo-ipi portion, it's for the maintenance portion. In combination with cabo for first line treatment. Monotherapy for patients with renal cell who've received prior anti-angiogenic therapy, so TKI, or if you have a non-TKI anti-angiogenic, and then monotherapy for patients with unresectable or metastatic melanoma. Important to notice there, it doesn't talk about adjuvant yet, but let me keep going. Monotherapy after nivo-ipi. So again, it could be monotherapy or it could just be the maintenance part of your nivo-ipi regimen, not indicated in combination with ipi. It's monotherapy for the adjuvant treatment of patients with completely resected stage 2B and up melanoma. So that's Checkmate 238 and then Checkmate 76K equivalents. And then here comes some other indications in combination with platinum doublet as neoadjuvant treatment, non-small cell lung cancer. Boom, neoadjuvant treatment. In combination with platinum, chemo, neoadjuvant, non-small cell without EGFR mutations or anaplastic lymphoma kinase, ALK rearrangements. Okay, keep going. More lung cancer indications, metastatic non-small cell lung cancer with progression on or after platinum-based chemo, and targeted mutations should have been treated prior to receiving this, not for use in combination with ipi. That's stated over and over on the label. monotherapy for the treatment of adult patients with recurrent or metastatic squamous cell of the head and neck after platinum-based chemo, monotherapy for the adjuvant treatment of patients with urothelial carcinoma at high risk of recurrence after surgery, in combination with cis and gem for first-line treatment of metastatic or unresectable urothelial carcinoma, monotherapy for patients with locally advanced metastatic urothelial who have disease progression following platinum chemotherapy or within 12 months of neoadjuvant adjuvant containing platinum, monotherapy for adjuvant treatment of GE junction cancer or esophageal cancer with residual pathologic disease after neoadjuvant chemoradiation, combination with fluoropyrimidine and platinum-containing chemo for esophageal squamous cell carcinoma, first-line treatment, not in combination with IPI for metastatic esophageal, maintenance after fluoropyrimidine, platinum for metastatic esophageal, and finally, metastatic gastric, GE junction, and esophageal adenocarcinoma in combination with chemo. We can cut all that. That may not be necessary to read all of this, but
Yeah, but I mean, the obvious take home there is that it seems like it's most of the indications, number one, and
yep.
then the second obvious thing is that the combinations. It seemed like they were quite widespread with chemo and with targeted therapy, with the exception, obviously, of IPI, and so that in itself is quite interesting. And I certainly don't know anything about that, and I have no idea what the reason for that, actually, whether that's a decision or whether further data were asked for to, and they don't have those data at the moment. Yeah, so it's pretty interesting, actually.
It's interesting that it can be studied as monotherapy, but then approved in combination without. Yeah, that's quite interesting. And then eliminating IPI here. I'm going to read one last statement about subcutaneous and administration with a grain of salt. This comes from the sponsor's website. Several potential benefits of subcutaneous administration include flexibility for the provider and the patient. It may impact chair capacity, it may reduce time spent preparing and administering treatment. That's interesting because, as you and I have both said, we're not even sure about how you prepare this and inject it with hyaluronidase. What's that preparation look like? It may also simplify administering treatment for patients with difficult vein access. That's true. We had not actually said that, but that's a good point. And it can be administered by a healthcare professional without site of care restrictions. So brown bagging, white bagging, maybe that kind of stuff. I guess the final question I could ask you perhaps in closing, where do you see our future clinical trial designs going? Should we be designing trials with Qvantig or with off-patent Opdivo and then drawing some conclusions? What do we do?
I don't know. I think you have to have both options included and maybe not even specify.
And then providers, patients can choose whichever and flip it in and out because
I'd have thought so. I mean, and that's probably pragmatic because one assumes that this is going to get reimbursed, certainly in the US, and people are going to use it. And so then I think with the trial design, you just need to be practical about that and allow both. I don't see how you could do it really another way.
As long as the schedules.
Sorry. Say again?
As long as the schedules line up.
Yeah, so that's an issue as well, which is going to add some complexity, I guess. But we'll just have to suck that up, as they say. I think. I don't think you can easily I think if you were trying to stipulate one or the other, it would just to make it more difficult to recruit into trials, actually, which is a bad thing because it's difficult enough already.
Last thing, as I'm looking at this brand label, Opdivo Qvantig, nivolumab plus hyaluronidase and VHI, which makes me think it's whatever. Subcutaneous injection, 120 milligrams plus 2,000 units per ml. And the approved dose is 1,200 milligrams plus 20,000 units of hyaluronidase. So that's a 10 ml subcutaneous injection. So again, this goes back to my question. At some point, I would love to hear from patients or have us actually ask the patients if we ever have the luxury of like you're saying, choice here, and it doesn't come down to kind of a regulatory or reimbursement heavy hand decision. I'd love to hear from a patient how they feel about getting a shot for less than 5 minutes. That is basically 10 mLs. That's 2 teaspoons worth of medicine.
Yeah, but I think the way it's going to play, honestly, is that we won't be making these decisions. That it's only on the National Health Service. This will be, assuming it's reimbursed, and we get regulatory approval here. This will become, if you like, the sort of de facto, and then for the patients who don't tolerate it, then they'll get switched to IV afterwards, I think. And so, what the question will be: what is the rate in kind of real world practice of people not being able to tolerate it and change to IV?
So that brings me to something. If you have time to before we record a fact check, maybe you could chat with some of your breast colleagues there. Certainly, you guys have switched to a trastuzumab formulation in
Long
some
time ago.
patients. Yeah.
Yeah.
So maybe we're having philosophical questions about something the breast world has already sorted through, which is, look, it's not a patient's choice. As much as we'd love it to be a patient's choice, it's not. It's a reimbursement, regulatory choice. Secondly, what is the percentage of patients who can't tolerate, who then have to flip out? If it is ever a choice, how many times do patients choose or not choose? You and I have talked about even this, just the idea that some cancer patients really value the interaction with their team and their infusion nurse and the care that coming for an infusion feels like. It feels like an hour or 2 hours of their every few week time where the healthcare team wraps their arms around them. Whereas a 5-minute or less than 5-minute subcutaneous injection may just feel like another quick touch to the healthcare system that doesn't feel as valuable to them as feeling wrapped up in the arms of an infusion, et cetera.
Yeah, I think that's a great point. I think the way you said it was lovely as well, actually. The metaphor there. And maybe we underestimate all that sort of stuff. And anecdotally, I think, lots of patients actually do value that contact. And it's kind of in an informal way because they come and see us, and a lot of it is quite formal, whether we like it or not. And maybe if it's like you say, just a 5-minute injection, you lose all of that.
Mm-hmm.
But that's a great question. But yeah, well, I'll maybe chat to some of my colleagues who treat breast cancer because they, like you say, they've been doing this for a while.
Cool.
And yeah, see what the feedback is. Yeah, okay, we're
Cool.
good.
Great. Well, that was a great one. Thanks for teaching us about sub-Q nivolumab. Hi, everybody. Welcome to a fact check for Opdivo Qvantig. We had a couple of things we were chatting about that we were going to check, like how many sub-Q drugs have been approved in oncology. What is the breast space doing with this? Have they adopted it full stop for everywhere there's a HER2 trastuzumab? They've gone to sub-Q. And then just what the experience is like at the patient end. So you did some.
Yeah, we should say the date though, first of all.
Today's date?
Yeah,
Why? Oh,
because
come
it's the
on.
20th of January,
That's MLK.
2025.
Very
Sorry?
big. It's a public holiday. It's Martin Luther King Jr. Day.
Yeah,
That's very significant. Is there
yeah.
something else happening today?
I don't know. It's Owen's birthday.
Ah,
Owen's 40 today.
happy Owen.
Oh, yes.
Happy.
Happy birthday, Owen. So,
It's very check. He's never going to watch long enough to see this.
what? I'll tell him when I see him. I've got my Rogue US t-shirt on as well. Anyway, so getting back to subcutaneous. So I chatted to one of my colleagues last week or the week before about subcutaneous trastuzumab Herceptin, which they've been using for a little while. So it's got approval. It's reimbursed here. And then I was asking some of these questions you and I had been talking about, what's the volume, what's the practicality, what's the patient acceptability? And to cut a long story short, Alicia, my colleague, told me that 99% of the breast cancer patients are on subcutaneous trastuzumab. And I said, well, what about the 1%? And that's people who, for whatever reason, don't want to go onto subcutaneous. They've been on IV for a while and they've got a view and belief, if you like, that the IV is working, stuff like that. It's 5 mils, this formulation, delivered over quite a long period of time, a few minutes anyway.
This formulation, you mean the breast cancer formulation?
Yeah, correct. Yeah. So it's 5 mils. And so it's not as much as 10 mils, but nevertheless, it's not a tiny volume either. Yeah. Most of the patients are injecting it themselves at home.
Okay.
And so then I said, well, how do you actually really slowly give 5 mils by an injection? And I think the reality is that it's just going to be kind of very tiny subcutaneous boluses. And of course, no one's monitoring the patients doing it at home. So who knows whether they're really giving it over 5 minutes or not. So there isn't precision, and there can't be, I don't think, because of the limitations of human physiology, with actually giving it very, very slowly over 5 minutes. Go on, you were going to say.
Well, it's like you were saying, I was looking at the Institute of Safe Practice Guidelines, Safe Medical Practices for IV push, and it technically says exactly what you say. There's like no way to actually adequately simulate or practice this. And maybe you and I talked about this, or maybe somebody told me in reality what it is. It's like a little bit of a push, then wait.
Yeah. Tiny boluses, I think, realistically.
Yeah.
So that's what's happening. And so then the people who aren't injecting themselves, I mean, let's say if they've got bad rheumatoid or something, maybe that would be an example. It's difficult. Then a nurse would be doing it. And I think that could either be kind of in the clinic, if you like, or maybe even at home if it's we call them district nurses here, community nurse. And the patients love it, is the other thing to say. They absolutely love it. So then my next question to her, Alicia, was to say, well, what about that whole thing that you and I talked about, which is the environment of coming up to the hospital, maybe, sitting in a chair, talking, getting to know the people on the day unit, other patients. And what she said to me was that actually no one really rued that or was disappointed. And do you know what? I mean, what I think about that is that, of course, there'll be some people who do value that. How could you not? Because that's normal for humans. But I guess the upside and the convenience of having subcutaneous treatment will outweigh that downside for a lot of people. And of course, this is an anecdote, isn't it? I talked to a colleague, all that sort of stuff. I think the only way to really nail this is going to actually to get some data from patients. Go on.
I'll be excited when we can use it to see, because as you have now explained that this is how your colleague is describing it, I wonder if the touch on the patient, the showing up, the hi, hello, the socializing isn't more for me than it is for the patient. I think, it's the patient who must feel a lot of reassurance seeing us and getting us to lay our hands on them and then approving the treatment and blah, blah, blah. And you're saying, no, the upside of like faster, shorter, it outweighs the human touch part of it. I wonder if that human touch part then isn't just more for me then. So it'll be interesting when we get to use it to see.
Yeah, but I don't know. I mean, that's going to be so heterogeneous at the risk of being cliched, because I think different people value different things. Different physicians, clinicians, because it's not just doctors this, okay, will have different relationships. We all know that we all have different relationships with our patients. And so I guess there isn't going to be a one size fits all. But I guess my prediction will be that you put that whole thing together and actually we'll see the same thing in other indications and other situations where actually the patients will say, no, I'd like to do it like this, please. And it's not like they're not going to still have some of that community for other types of reasons. I mean, they might talk to people in the waiting room. Let's say they're still going to come and see you in clinic. They're still going to have relationships with their nurse specialist, that type of thing. So I don't think it's going to disappear altogether. Anyway, so it was gone. I was just going to say it was useful thank you, Alicia, number one, but it was great to get those insights,
I think it's really interesting when I think of the relationship with like a GP. Let's say you have blood pressure issues or thyroid issues. You really only interact with them a couple of times in a year, maybe once a year. And then the remainder is just over a portal, reporting a symptom or asking for a refill, or a winter event, maybe something's happened. It's a very light touch And in oncology, it's just like I've gotten so used to seeing our patients so regularly, even 6-week dosing. I sort of like to keep a lasso on them a little bit and do labs. And then I like to review the labs and speak with them. But more and more, you're outsourcing that. You're having your nurse do that, or your, APP, advanced practice provider, call them in between or clear them. And so with sub-Q, what I suspect will happen is obviously we'll start the process and we'll start the sub-Q with them. And then any mild side effects reporting or things like that, management will all happen via a portal. Very few visits, maybe with a different provider, your nurse or your advanced practice provider. And then you're bound to see them at a scan visit. So now you're going to go down to seeing them, from every 3 weeks or every month to maybe 3-4 times a year, just to sort of like review a scan and say, which is perfectly fine. This is how we interface with our GPs, and we feel beloved with our GPs. I've just been so used to interacting with these patients and their families on a much more routine basis. 4 times a year, I don't know if I am going to have time to ask them about their dog and the graduation and the holidays. But when you see them every 3 or 4 weeks, you get to know them a little bit more as humans. Anyway, this whole thing may be more of a toll for me than it is for them.
Yeah, well, listen, I agree with all of that. I really do. And it's nice to see people, routinely when you are talking about some other stuff and not it always just being kind of talking about the cancer. That's true. By the way, is it definitely a lasso that you use, like a TED lasso or lasso? Because we say lasso. And if that's a real bona fide difference, then that's like a new discovery today.
Lasso?
Yeah, we say lasso.
Yeah, it's lasso.
And aren't there two O's on the end, or is there a difference in spelling? I think we might need to do a fact check of a fact check. Yeah.
Cute. I'll put it in the show notes. Okay, the other only probably last thing to say is how many sub-Q drugs there are in oncology.
Yeah.
Rituximab.
Yeah, so we don't really know, but it's quite a lot. Atezolizumab here, definitely.
Atezolizumab and nivolumab.
Yeah.
I think it might only be the 4. I mean, there's growth factor if you count growth factor.
No, but let's just kind of stick to. Yeah. Okay.
I think it might just be those 4. So,
There'll be more. But that's where we are now. Yeah.
Okay. All right. Good job. Good fact check. Hi.